Right, okay. So as Verity said, my name's Hugh. I'll give you a slide in a moment to give you a little bit of a background. Verity asked me to talk to this topic, title, whatever you want to say, which caused me some grief. I knew where she was trying to get to, and actually as I put the slides together, I landed up with a rather different answer than one I think she suspected I started from. So that's where we're starting, with a collision of worlds in neuroscience. And we may land up at somewhere rather different. Now, who am I? So I anticipated having to introduce myself, which was fortunate, but anyway. I'm slightly different from the other two speakers, that I didn't actually start out as a psychologist. I actually started out as a physiologist and pharmacologist with an interest in statistics and computing. However, I did an undergraduate degree that meant I had to go out into the big bad world and work for a year while an undergraduate. And while out in the big bad world, I had to do some practical science to earn a crust during my year out. And I landed up doing my first psychology experiment back in 1982, which I think puts Andy into a cocked hat. So that got me going, that I thought psychology was something interesting and important to the sorts of things I wanted to study. So once I finished my degree, I then was trying to work out what to do next. Decided to go and get myself a job for a year where I worked out what I was going to do, and landed up in Cambridge working with the ubiquitous Trevor Robbins, who's already been mentioned once. And in fact, what I was actually employed to do was to write the graphics for what Andy now sells.
Oh, well done.
But I only managed to do that for 6 weeks. Before it turned out the guy who was testing the rats wasn't very good at testing the rats and preferred doing the graphics, and I was better at testing the rats. Could do the graphics as well, but I did the rats instead. So after a little while of testing rats for various different reasons, when I was supposed to be writing pretty pictures for Cantab, I worked my way through the undergraduate psychology degree at Cambridge, so I didn't actually sit the exam, but got my grounding in psychology, and then went on to do a PhD in Cambridge, where I was looking at cholinergic systems and cognition, which again, you'll have heard a little bit about in Andy's talk. Felt I needed to change the scene after that, spent 2 years in the States, working national drug abuse on the neuroanatomical substrates of cocaine addiction, which was good fun. And then came back to the UK and have been based in and around Edinburgh for quite a long time now. I did 10 years at the University of Edinburgh, where I was part of the Department of Pharmacology and the Department of Neuroscience, attached to what was referred to as the Fujisawa Institute of Neuroscience. So this was a sort of halfway house between academe and industry. I was doing a mixture of projects, but that's where I began to learn some of my business skills in this sort of nice comfy zone that I was in academe, but I was being paid for by industry. After 10 years of that, I then jumped full lock, stock and barrel into pharma and worked for a Dutch company called Organon, that then got bought over by a company called Schering-Plough, which then got bought by Merck, which you will have seen up on the list. While Andy was trying to flog his stuff to Merck, I was sitting on the other side of the desk saying why we should buy Andy's stuff, but it still didn't get done very quickly, but there you go. So I spent 10 years in big pharma, and that's really where I'm going to concentrate a little bit of my talk, and I'll explain why. Because Merck had some very good research capabilities here in Scotland, between Edinburgh and Glasgow, a place called Newhouse, where we had about 260 scientists working on neuroscience programs. In fact, we were quite successful. We took an antipsychotic to market, we took a neuromuscular blocking reversal agent to market, we took another 9 molecules into man, which for a small site is a pretty prodigious record. However, we didn't survive all the cuts that are happening in big pharma at the moment. So big pharma has always been the mainstay of where the money for neuroscience and psychopharmacology research has come from, maybe since the 50s. My message today to you guys is it's gone. It's gone, bye-bye. But you guys are very, very well placed, and this is the theme that was in Andy's, and I want to build on it. You're incredibly well placed. If you want to go into some of the things that Andy and I have been working on over our professional careers, there is a renaissance happening, and we need people like you to move into that renaissance, but perhaps with a slightly different mindset from the one that perhaps I was looking at 20 years ago. I've managed to maintain some sort of academic credibility and have a post here in St Andrews, so you may see me around occasionally. And if everybody wants to come and talk to me, get in touch with Verity. I'm up about once a month, very happy to talk to people offline. I'll come back at the end to say a few words what about I do now, but I now work for a by a tech company based in Edinburgh. There are only 10 of us. We do the opposite of what Andy does. We spend money. So the guys who set the company up managed to raise 10 million about 3.5 years ago. And our job is to spend their money and try and make drugs. So I'm effectively what's referred to as a drug hunter. We're in the lucky position now that we're 3 years in and we've still got as much money in the bank as we started on day one, which we're not unhappy about, but we're still burning it at a fair old rate. And I suspect the third speaker may know more about the business dynamics than I do. So what I want to talk a little bit about is what's been going on in big pharma in neuroscience and why that area is changing. If you understand some of the reasons why it's buggered off out of neuroscience and psychopharmacology, you might then perhaps get enthused to go and do things slightly differently. So, Andy's covered this already a little bit, but if you were in big pharma in the grand old days, maybe 10 years ago, when you were part of a neuroscience department, you'd had all sorts of things you could have decided to try and design your drugs against. The ones that will obviously come to mind are things like Alzheimer's, Parkinson's, and Huntington's disease. You've got neurological disorders such as epilepsy, stroke, traumatic injury, brain dysfunction, aphasia, apraxias, etc., neurodevelopmental disorders, affective disorders, sleep disorders, pain, migraine, neuro-oncology, drug misuse, and eating disorders. And that's as far as I could get before I filled the slide up. I could carry it on a little bit longer. Now, some of those you may not think, as classical psychologists, are areas that you can go hunting in. You're wrong. They are all areas where psychology has some sort of component or impact. And if it's not psychology, it's neuroscience. And I think this is now the school of psychology and neuroscience, and maybe there's the odd neuroscientist in the audience. All of these are pertinent to the sorts of skills you're learning here. And there may be ways that you can use a new insight or a new approach to have a crack at something on that list. And a lot of the more small print things, which I've not put up there anyway. So why was big industry interested in neuroscience? And Andy's already probably answered that question for us already, but just to give you some examples, Prozac, which was one of the later antidepressants, where's the pointer there? In 2000 reached peak sales for Eli Lilly, the company that held the patents to it. At peak sales, it was making $2.4 billion a year for Lilly. Accounted for 25% of the company's turnover. So these are big numbers, serious amounts of money. And depression is still there, out there. In 2010, there were 24.4 million prescriptions for the generic formulations of paroxetine. In the UK, and that was in the States. In 2011, so last year, there were 6 million prescriptions for fluoxetine. So fluoxetine has now come off patent, as it's described, and that's an issue you need to understand, that when you have a new chemical molecule, and this is the chemical structure of fluoxetine, the chemist brew up, at some point, the chemist who invented that structure will have written a patent, and that patent will have been filed, and from that point onwards, a clock was ticking. And the company has to make enough money while that clock is ticking to cover the costs of developing that molecule and make a profit and make enough money to start research on the next molecule. So even though it's turning over huge amounts of money, and you would therefore assume that these companies are making wacky profits, and don't get me wrong, they're not doing too badly most of the time, but an awful lot of that money goes back into covering the research that made it in the first place and funding the molecules that are coming through beside it. But that may give you an idea of why depression is of interest. Andy's already told you a lot about Alzheimer's, so I won't dwell on this too much. I hope my numbers add up vaguely to Andy's. I think some of them are maybe 100,000 out one way or the other, but I think the same ballpark, fortunately. So estimated cost, and these are the sorts of things which drive both governments and companies. UK economy, the Alzheimer's Society estimates it's going to cost the UK 23 billion in 2012 just coping with Alzheimer's. There are 8,000 sufferers in the UK, 5.4 million in the US. You already heard some of these. Now, donezepil is this molecule down here. It's an anticholinesterase and changes the cholinergic function in the brain. It does have some clinical benefit. Does it stop the disease? No. Does it fully reverse the cognitive deficits? I would suggest no. Hopefully Andy's not going to shake his head and disagree with me, but it may blunt it, but it's not going to do an awful lot. There's an awful lot more we can do, either to halt the progression of the disease or help with the cognitive deficits. However, this compound, even now it's generic, so its price will have come down significantly. When the company that makes the molecule flogs it under patent, you'll probably on average pay 5 times more per pill than when it comes off patent and a generic company in Far East is making it. But even at generic sales, it's turning over 2.3 billion a year. So what are the business drivers that are pushing these things forward? Historically, neuroscience, and that encompasses psychiatry, has been extremely profitable, as I've hopefully demonstrated. The disease affects a very large component of the patient populations over the world, so therefore the markets are large. The disorders that we're talking about on the whole are increasing. The Western world is an aging world. There'll be more old people, there'll be more dementia, the market's increasing. The same's true of psychiatric disorders. As fewer of us die in young life through infectious diseases, rather things, then you're going to be landing up seeing more of these things coming through. Many of the disorders we're talking about have no cure. So there is no way that we can cure depression, schizophrenia, Alzheimer's, Parkinson's. We may be able to alleviate the symptoms, but we can't cure them. And when we are trying to alleviate the symptoms, we're often not particularly effective. There may be bad side effects, there may be resistance, or all sorts of issues there. So the drugs are not perfect. I've made the point there that they're more relevant to the worldwide. So in principle, one would imagine that neuroscience is still very attractive to big pharma. But there are issues, very significant issues. So this is a well-used graph from a paper back in Nature Review Drug Discovery 2005 from a chap called Ismail Kola, who I used to work for in the bad old days in Shearing Plough. And what Ismail did was actually review pretty much what was going on across the pharma industry, and actually wrote a very pivotal paper showing that if you took 100 drugs that we were trying to work towards CNS, only 9 of them would ever make it to market. So 9% of the ideas that I would have come up with actually got all the way to a marketed drug. In other words, so 91% attrition, very high rate of attrition, awful lot of failures. Oncology is another one where the attrition rate is extremely high. Even in the best case scenario, cardiovascular, you're getting 80% fall off in ideas that actually get through to the market. So there are lots of things that we could do better to improve this, but most of it is getting good ideas in at the bottom. Up here, what you'll see is why things are failing. And really, I won't worry with the complexities of it, but the big light segments are labeled efficacy. So even in phase 3, which is the last stage of drug development before you get a license from the FDA or a mayor, in 2007 to 10, 66% of the drugs failed just because they didn't work. They didn't do what we thought they were going to do. So that's a bit of a worry, but that does mean that therefore there is room for good science. So trying to map onto our collision of worlds, maybe it's forces operating in different directions. So if you think of yourself as a senior manager within a drug company, why are you going to invest in a particular project? Well, if you think you're going to make lots of money because you think there's a big market out there and lots of people want your drug, that's going to put you in the positive side of the equation. If you think there's a clinical unmet need, that means that there's probably room for you to come up with a better drug or a better biologic or even a better tool as Andy develops. So if there's a clinical unmet need, that's a driver. Political pressure often actually makes a difference, particularly in the Western world. So for instance, you can see there's an awful lot of pressure out there at the moment to find drugs for Alzheimer's or HIV or cancer. But if you remember back to Andy's early slide, up the top of his figure, he had problems with drug abuse. Now, there isn't very much political drive to develop approaches for dealing with drug abuse. Is that a biological problem? Is one more or less difficult than the other? I would argue not. In fact, actually, animal models of abuse liability, the understanding of the human drivers is actually probably one of the best understood areas. But in terms of political drive, are you going to get support from a government? Probably not. And that alters the grant funding and all sorts of other things. On the other side of the equation is cost of research. We'll come to that a bit more. Cost of development. So that's taking it from preclinical into humans. The probability of success, which I've already said, is probably fairly low. Lack of preclinical translation, I'll touch on that a bit later on. And then there's concerns over safety and hence liability. If you don't think the drug's safe, or you don't know what it's going to go and do, you will not move that into the market, not because it may not do what it's supposed to do, but because you're worried that you're going to get sued because it did something you didn't expect it to do. And that really, certainly in American drug companies, is something they're hugely terrified of because of the litigatory neighborhood outside the companies. So what are companies working on at the moment in neuroscience? If I put this slide up 4 years ago, the list would have been very, very positive and very, very long. But most of the big pharma are still doing some Alzheimer's work, but not very much. There is still work going on in Parkinson's and Hunt's, and I'll try and explain why in a little while. But very few are now working in psychiatry, pain, or stroke, mainly because of the very, very high failure rate and the very, very high cost of moving those projects forward. What are they working on? Most of the projects in Alzheimer's are looking at disease modification, so trying to arrest the progression of the disease. Until about a year ago, the great white hope was gamma secretases. They actually, when they took them into the clinic, not only did they not work, but they actually made the patients worse. So that stopped. Good. That's a good thing to stop reasons when people get worse. Beta secretases are closely related. They're still in the clinic. And the next, and perhaps the last gasp, will be the hyperphosphorylated tau approaches. They're all disease modification. So compounds such as Aricept, the cognitive enhancer, there are very, very few big pharma who've got cognitive enhancing programs still underway. In fact, they're trying to sell them off quicker than they can manage. Parkinson's, looking for improved motor symptoms via dopamine and adenosine pharmacology, and also again trying to go after the disease modification via LRRK2, which is one of the mutants you find in Parkinson's disease. Huntington's disease is becoming more popular, and that's actually probably symptomatic of what's going on. Huntington's disease is one of the few neuroscience diseases where we really know what's going on in terms of the genetics. You can nail Huntington's perfectly on the genetics, and we probably know what's going on in terms of the pathology. However, even though we know precisely what is going on, we still haven't got an effective therapy for it. And that's a fascinating insight into how things are going. But nearly everything these days is now referred to as hypothesis-based. So you've got to come up with an idea before you get somebody to invest in it. And that's maybe where I'm putting a plea out for you guys. You're at the start of your careers. You can come up with a new idea, whether it's for a new instrument or a new approach, then go and talk to people like Andy. If you can come up with a new way you think a disease is progressing or a new target, come and talk to people like me. But we need new ideas. We need better understanding of these disorders. I'll click over this on the basis of time. But really, the other sorts of things we need in drug discovery is serendipity and luck. Nearly all of the major psychiatric and neuroscience drugs were not chosen by intellectual effort. They were chosen because of good clinical observation and good science. But you do need a hell of a lot of luck to do it. Just to give you a context and to give you some idea, a little bit of psychopharmacology very briefly, to give you an idea of perhaps how things can move forward. In 1937, a chap called Daniel Beauvais at the Pasteur Institute developed this molecule, pyrilamine, which was the first antihistamine. So this worked against the histamine receptors in the brain, in the body. In fact, it goes back to 1910 when Rang and Dale first discovered the histamine receptor itself. So if any of you have got a pharmacology textbook, you might have got Rong and Dahl, and that's what Rong and Dahl was to describe histamine in the first instance. 1941, actually in German-occupied Paris, the first antihistamine was actually taken into man. So this one had a very bad profile, so it didn't go into man. This one did. And then diphenhydramine, 1943, was discovered in Cincinnati. Probably all of you at some point have taken diphenhydramine. If you've taken Piriton, which is an early antidepressant, so if you've got a nasty sting on your arm and you want a nice peripheral, strong-acting antihistamine, then diphenhydramine is a pretty good one. So it's still out there, it's still selling across Boots counter, it's still making money for somebody. But what actually, in retrospect, we found out was it not only is an antihistamine, but it's also a 5-HT reuptake blocker. And in 1946, what Paul Charpentier did was demonstrate that a lot of these antihistamines had sedative properties. So not only did they damp down the triple response for histamine, but they also made people rather quiet and slightly sleepy, which is things you associate with antihistamines, but it may be the 5-HT. So he took promethazine and changed the chemical structure very slightly. So hopefully you can see, even though most of you are not medicinal chemists, there is actually very little difference in the chemical structures. And that came out as chlorpromazine, and that had a calming effect. Now, they actually went into asthma patients first, because the whole idea was it was an antihistamine, and you would calm the histamine response. Now, actually, it didn't do very much good at getting rid of the histamine response, but everybody felt rather happier at being, or rather more relaxed about having asthma. Actually, it turns out that it was a very effective antipsychotic. So it was the first antipsychotic. And nearly all the antipsychotics have been developed from that basic chemical fingerprint, but it came from very good clinical observation of what was going on. Now, that clinical observation in this case was in a human. There's no reason why it shouldn't be in a rat or any other species, but good psychological science discovered that molecule effectively, not the chemist. Diphenhydramine, going back a step, goes to this molecule, which is imipramine. And that they took into schizophrenics because they thought that because it was like this one, it was going to have the same effect. Unfortunately, these were schizophrenics who at that time were not having an active psychotic episode. When they gave them this drug, they all became psychotic. So it did the opposite. However, that turned out to be the first antidepressant because it worked in the opposite direction. So but just by tweaking a few molecules in that structure, you've got one that's an upper and one that's a downer. And you get your antipsychotics and your antidepressants. But what I want you to see is that all happened in 1950. And we're standing here in 2012, and really it hasn't moved on about more than 3 millimeters from there. But it was some very, very good science there which gave you those drugs. So really, last 20 years, not very much has happened. Prozac, which we showed you up front, was that hugely good drug for Lilly in terms of the amount of money it generated. Prozac was first worked on back in 1971, which is only 20 years after that first discovery. Really, it doesn't move on in terms of chemistry or ability from those early molecules. This gives you an idea how long it takes for a drug to be born, tested, move into man, be marketed, make $1 billion a year, and then die effectively from the person who's actually developing it because you've run out of the patent. So Prozac ran out of life, as far as Lilly was concerned, in 2001, about 30 years after it was first discovered. So it's 10 years before it goes public, then you've got about 20 years patent life. So why are there issues in psychiatry and neuroscience? Now, actually, again, building on some of the things that Andy's already said, one of the problems in psychiatry and neuroscience is that the way we look at these disorders is through qualitative assessment of the symptoms. We're not doing the same as you would if you're doing a cardiovascular drug, where you can walk into the clinician's surgery, get your blood pressure measured, it's high, you take a drug which lowers your blood pressure, you go back a fortnight later, and your BPs come down. Hard clinical evidence. Here, we're working on scores, parameters, scales. They're qualitative. The patient that Andy demonstrated in his video clip, you saw first-hand evidence there that that chap was misdiagnosed initially. These things are very, very difficult to diagnose unless you really understand what's going on and you're very well trained, or you've got better tools, and that's what Andy's trying to do in his area. But without the sorts of clever tools, more intelligent tools that people like Andy are developing, and hopefully you guys will, we can't diagnose people into proper domains so that people like me can then fit the drugs that then the clinicians can use to make them better. But you've got to identify those patients, subdivide them, understand what's going on in their heads or their spines or wherever the disorder is, so that we can understand the biochemical system, so that we can design the drugs, which we then need Andy's tools again to prove that they actually work. But we need those new ideas going in. The patients in most of these disorders exist on a continua. So you've probably had a bad day, we haven't been feeling too good, you're sad. Are you clinically depressed? No, you're not. Are you somebody who might become clinically depressed? 30% of Western world humans will at some point have a psychiatric diagnosis against their name. So we're all susceptible to these sorts of things. It's all a matter of degree. That makes it much more difficult to measure. The genetics are complex. Apart from one or two disorders such as Huntington's disease, frontal lobe dementia, some of the smaller diseases, it's very difficult to pinpoint somebody who's actually going to go and do it. Certainly when I was a postdoc working on Alzheimer's disease, we had great hopes that maybe there'd be 4 or 5 genes we could identify, which would give us a fingerprinting tool that we could go out, measure people and say, right, this person's going to get Alzheimer's at the age of 50, that person's going to get Alzheimer's at the age of 80, this person's going to get a different sort of Alzheimer's. Current view is that there probably are somewhere in the region of 50 to 60 genes acting in Alzheimer's. Schizophrenia, again, D2 antagonists have been a very good treatment. We'd hoped that by looking at schizophrenia, we would be able to get a genetic code which enabled us to identify people, because we want to start treating them before they translate as teenagers into people who have florid psychosis as young adults. Currently, one of the best groups down in Cardiff have been doing this, reckons between 150 and 200 genes that you need to understand in order to fingerprint. So these are just jobs which are too bloody difficult for us to do at the moment. I think I've said a little bit about the etiology, clinical trials. Right, now, if people want to talk to me about clinical psychology in relation to clinical trials, I won't worry you at the moment. What I will say is that most of the issues we have at the moment in terms of why moving drugs forward for psychiatry is not attracted to big industry is because the clinical trials fail so often. And one of the reasons why they fail so often is that if you've got people who've got a psychiatric disorder who are not particularly well treated, even when you just start being nice to them, they get better. It's very simple, but it's actually true. Give them a good diet, make them feel better, feel wanted, they often get better. Therefore, you get a huge placebo response. There are other much more dangerous problems about placebo response, but doing the clinical trials is difficult. And that then leads on, if you can't get good clinical trials, you're going to get poor drug approvals. And the costs are going up all the time. I was part of a big team, a huge team, that took an antipsychotic to market, a compound called acenapine. Went on sale in the US 18 months ago, went on sale in Europe just over 2 years ago. I know for a fact that cost the company $4 billion to research, and it took us 18 years to get there, from the day the molecule was first synthesized to the day the first doctor could write a prescription. If it's going to cost you that amount of money to move things forward, you've got to be really bloody certain that you're going to get there in order to invest. So therefore, maybe we need to go after smaller bite-sized bits of science. I'm getting towards the end now, but just sort of making my last comments. Most cultures report a 30% lifetime risk of mental illness, so it's very, very common. Come on. All cultures are aging, so issues associated with aging and the comorbidity in aging is always very important. So you've heard of Alzheimer's, but the other sorts of things, you'll end up getting more cancers as you get older. Cancer has an effect on your psyche. As you get older, your issues with pain get more. Again, they have interactions with the CNS and psychology. More people end up getting strokes, which needs people have therapies, approaches. All these things are associated with age. As you get older, you land up with more diseases. As you land up with more diseases, we need more ways of helping it. So it's not just Alzheimer's, which is a problem with aging. That's pretty much the same one there. And I think Andy's already covered that one, giving you some idea of what's going on in the USA and Canada. But these are big numbers, and therefore we need to solve them. What do I want you to go away with? Research is always cyclical. There are cycles, there are fads, there are flavors of the time. At the moment, psychopharmacology and neuroscience in big pharma is out of flavor. It's not an area to go and try and get yourself employed by GSK or someone like that as a neuroscientist because they're not employing very many. In fact, they're sacking them quicker than they can make them. However, it is cyclical, and if we can build up new ideas that can go in at the bottom, then maybe we can go in the right direction. I don't believe that going after disease modification is the be-end-all of neuroscience in the next 15 to 20 years. I think it's just too complicated. However, going after symptomatic relief, when the big companies realize that they can't disease modify and the governments are still clamoring to get these health bills down, then maybe we'll go back to symptomatic relief. And that means that people like me and Andy get back into the business again. But hopefully you guys can help us do that. Psychology, neurosciences help us enable these, should bring forward progress. A new era may also be emerging, but because an awful lot of these big companies have now moved out of research. Merck, for instance, used to be one of the highest spenders on research, out of research and development, R&D. They now are one of the lowest spenders on research. And in fact, the CSO of Merck has gone on record that Merck's research strategy now is not R&D, it's S&D, it's search and discover. In other words, they have teams of people scouring the world, looking for people like you who've got great ideas that they can move molecules forward, or hopefully people like me are actually doing the drug discovery. So it'll be small groups of people who invent those new drugs. Now, we heard mention of Janssen earlier. Paul Janssen was one of the most prolific inventors of drugs for psychiatry ever known. Now, Paul Janssen got his first drug to market using a loan of 14,000 Belgian shillings from his father. He built the lab above his dad's garage. He employed 4 guys, and he got the idea from the chemistry bench into man in 18 months. Small organizations are quick, they're effective, they can move to where the issues are, they can innovate fast, and they're cheap. Maybe that's where we need to go. All of you may be able to pick up on some of the ideas that Andy brought up and move these things forward. And maybe that's actually what we needed. We needed to get rid of big pharma. If we can come up, this is me sort of trying to, I didn't realize I was going to do it, but sort of selling Andy's tools. We need better ways of assessing what's going on. If we can work out what's going on better, we can design better drugs. And we need to integrate with other disciplines. You need to be talking to the pharmacologists, you need to be talking to the chemists, you need to be talking to the IT geeks. You need to be moving these together, and that will work. Right, so my last slide. Worlds apart, I actually think, is where we are in neuroscience and big pharma. I don't think the two are wedded at the moment. The collision has happened, and now the bounce away is happening. So I don't think there is a collision. But hopefully, innovative use of psychology, neuroscience, should be well. They help us engineer a new and more productive era for the treatment of all these disorders. Thank you for listening.
Any questions for Hugh?